Good morning, everyone. I'm Monzr Malki, Associate Professor in Hematology and Transplant in City of Hope and in LA. I'm the Director of the Unrelated Donor Bone Marrow Transplant Program. And I would like to start by thanking you all for being here and thanking the organizing committee for their kind invite. Those are my disclosure. None is relevant for today's talk. So with this slide, I show you the most known mutation in AML, including the incidence of each. The indication for that is that this disease is genetically heterogeneous, and we get to know this disease more and more. WHO has adapted this in their recent classification also, and included all those mutations that has impact on the prognosis of those patients. Understanding that precision medicine and targeted therapy is becoming very relevant in this era. I'm going to start now with my cases, and we'll discuss those accordingly. So Mr. Rara is a 65 years old male with history of prostate cancer, diagnosed 5 years ago, and had some treatment with radiation therapy, transferred to from local hospital with new diagnosis of AML. He's initially presented with fatigue and bruising. He underwent bone marrow biopsy, and this shows 10% blast. Repeat biopsy done here, indicating increasing in blast, and WBC was 1.5. Platelet were 10,000, and coagulation studies showed prolonged PTT, low fibrinogen, and increase in D-dimer. This peripheral smear shows this, and as we all aware of this, our rods, and the diagnosis is made for APL. This is the most common, this is the most curable disease that we deal with on daily basis. The main problem with this disease is the high early mortality. It's quoted in this paper to be close to 20%. The early mortality in this is mostly due to coagulopathy associated with this disease. In APL, there is increase in fibrinolysis, increase in coagulation due to tissue factor and damaging of the tissue, and increase in proteolysis. All of those, as we can predict, will lead to unbalanced coagulation and bleed. We do, how do we prevent that? We start ATRA as soon as possible, and we replace coagulation factor. And this is really complicated schema. I apologize for that. This is meant to summarize the management of this disease. But really, to make it easy for us to understand, we confirm diagnosis by translocation 1517. We assess the risk of the disease by looking at WBC, if this is above 10,000 or below. And we start ATRA and arsenic based on this work done in Italy 10 years ago. Adding GO or IDA is optional for high-risk patients. The main issue here is managing the side effects of the disease and the treatment. So we have to deal with differentiation syndrome, fluid overload, CNS prophylaxis, and ATO electrolyte imbalance, and EKG changes. This is what you would do in the first month after treatment. And this was all done based on the published data by the Italian that we are all aware of. So going back to the case, Mr. Orr started on ATRA and arsenic, and on the 8 days of the induction therapy, patient developed fever, increased shortness of breath, and a chest X-ray show bilateral infiltrate with a drop of oxygen saturation to 88%, requiring some supplement oxygen. So what's the approach in this patient case? This is differentiation syndrome. The pathophysiology we are all aware of is related to excess release of IL-2, IL-6, IL-8, and TNF. This all together will cause fever and increase in permeability, producing all those signs and symptoms. Important to note, time of onset and grading are very important here. With severe form of the disease is having 4 or more of those features. This paper is important. It has some details on management and prophylaxis guideline. I will refer you to it. Move on for the next case, sorry. Mr. Rux is a 35 years old, sorry, Ms. Rux is a 35 years old woman, previously healthy, was presented to local ER with fatigue, bruising, and gum bleed. Her CBC was abnormal, and a bone marrow biopsy was performed showing hypercellular marrow with 50% blood blast. This was positive for CD13, 33, 34, HLA-DR, and MPO. Cytogenetic results came back, and it was positive for translocation 821. So this is a core binding factor AML. What's the prognosis and what is the management? As we all know, based on the recent ELN, this will be considered to be favorable. And based on those curves, expectation for long-term cure will be in the range of 55% at 5 years. The main issue we deal with here is that patients who have c-KIT mutation will not have the same prognosis. As you can see in those curve on the right side, overall survival is significantly lower in patients with core binding factor and c-KIT mutation. Those patients require transplant. So in this slide, I try to summarize what we know about options that we use for younger patients who are fit for intensive chemotherapy. So on the left side, you can see induction chemotherapy options. And as we can see, people have been using 7+3 forever, adding now GO for specific subsets, and some data on flag GO. Patient with FLT3 can have a FLT3 inhibitor added, and people with therapy-related can have CPX based on recent data. Other options that have been attempted, including FLAG-IDA venetoclax, CLIA venetoclax, and CLAG-M. Patients who have mid-cycle evaluation of disease and showed no residual disease can go further for consolidation, while patients with residual disease need to be re-induced. Consolidation, as we know, will split to high-dose chemotherapy, including HIDAC, plus minus other medications, versus intermediate to high risk where transplant is needed. So gemtuzumab is a antibody drug conjugate against CD33, was first approved in 2000 and was withdrawn in 2010 based on the reports of increase in VOD in those patients treated with that. But in 2017, this was reintroduced with lower dose based on the ALPHA study. In this study, patients received GO, had significant improvement in overall survival. And as you can see, patients population on this study were CD33 positive, AML, aged 50 to 70 years. This was randomized phase 3 clinical trial and was positive and brought the medicine back again to market. The overall survival in this study was more pronounced in patients with favorable and intermediate risk. And high-risk patients did not benefit from that. Another study incorporating another medicine called dasatinib. This medicine can be used upfront therapy with core binding factor And this study is CLGB 1081, is a phase 2 study. It was done in multi-centers and had dasatinib added to the 7+3. And based on those curves, the approach seems to benefit patients with mutated c-KIT, as we can see improvement in their outcome. This is my third case now. Mrs. Vixus is a 65 years old female with a history of chronic kidney disease, breast cancer, had mastectomy and chemotherapy with radiation. She presented with a new diagnosis of AML. Bone marrow biopsy showed myeloblast at 30%, and her karyotype was complex. She had TP53 mutation. So what is the best induction therapy for this patient, and what do we do after? Understanding that she is not a transplant candidate based on her creatinine clearance. This is a very busy slide. I apologize for that. This is coming from NCCN, and it gives you all the treatment option for younger patients. For patients of 60 years old and older. In one of those sections in the middle, you can notice that there was a therapy-related AML and secondary AML, and the recommendation is to use CPX. So CPX 351 is a nano scale delivery complex with 5:1 molar ratio of cytarabine and daunorubicin. The data for this comes from this study, where patients aged 60 to 75 years with newly diagnosed therapy-related AML or secondary AML were randomized to 7+3 versus CPX on day 1, 3, and 5. Patients, as we can see here, receiving CPX showed significant overall survival advantage. Benefit was seen in all subgroup, including different age group and cytogenetic risk. So she went to remission, and what else? What can we do after that? She completed induction and consolidation, and in this study called COSAR, patients who are not eligible for transplant were randomized to receive maintenance therapy, oral AZA versus placebo. And as we can see on the right side on the curve, patient on maintenance had almost 10-month increase in median overall survival. Case number 4. Mr. Viale is a 77 years old gentleman who had history of hypertension, chronic kidney disease, stage 3, and presented to us with newly diagnosed AML. Bone marrow biopsy again showing 40% myeloblast, trisomy 8, and IDH1 mutation. So what would be our recommendation for this gentleman? Venetoclax is a BCL2 inhibitor which target oxidative pathway through mitochondrial-induced apoptosis. So killing of those cells will happen based on the high metabolic rate. And this was a landmark study where patients above the age of 75, unfit for chemo, got randomized to AZA with or without venetoclax. With venetoclax versus placebo, actually. CR/CRI was around 65% versus 30% on those patients who receive azacitidine alone. While CR was 35% versus 17% on this patient population. And as we can see, the primary endpoint is median overall survival on the right side with the curve. It was close to 15 months versus 10 months with azaven around 35%. And as you can see on the tail of this curve, 35% of patients are alive more than 2 years without receiving a transplant. In this complicated slide, we are showing response rate per different mutation and molecular predictor that we know of. And as you can see on top, patients with TP53, FLT3, and RAS pathway mutation are the most resistant to this approach. While if you look at the bottom, and you can see those responses approaching 80% to 100% actually with the IDH and NPM1. So this could be helpful information for us in our choice, as those patients with older age has multiple other options. VIALI-C is another study that was happening around the same time, where patients had low-dose cytarabine with venetoclax versus placebo in similar type of population. As we can look and compare these curves to the prior ones, there's a little bit less impressive, but still showing some difference in overall survival of 3 months. Another option for older patients who are not eligible for intensive chemotherapy could be, again, if they cannot receive venetoclax, could be glasdegib, which is a Hutch pathway inhibitor. In this study, patients above the age of 55 with newly diagnosed AML or MDS with excess blast 2, not eligible for intensive chemotherapy, were given this medicine based on phase 2 study. The treatment plan for this study was cytarabine 20 milligram per meter square on day 1 to 10, plus minus glasdegib 100 milligram daily for 28-day cycle. Median overall survival was improved from around 5 months to 9 months. Again, with some patients around 15% having long-term survival for more than 2 years. But there's a small trick here. Particular combination seems to be more effective in patients with good intermediate cytogenetic risk. As you can see on the right side, the curve showing poor cytogenetic risk patients who did not benefit from adding this drug to only low-dose cytarabine. Remember, our patient had also IDH1 mutation. So another combination that could be valid for this patient is ivosidenib with azacitidine. And this AGILE trial, patients were randomized to receive azacitidine versus azacitidine and ivosidenib 500 milligram daily. This was a randomized phase 3 European study in patients who are 18 years old and above with newly diagnosed AML with IDH1 mutation. CR/CRi was in the range of 53% versus 20% when you receive azacitidine alone. A median improvement in overall survival we can see on the curve is more than a year. The major critique for this study, though, is that Ivosi was not compared to venetoclax, which is considered to be the new standard of care in this era. Also, as we can see here in those, as we can, compare to the other numbers, CR/CRi was way lower at 50% when we compare with the prior data I just showed in IDH with the venetoclax achieving CR/CRi range of 80%. In case 5, Mr. Ratfi is a 59 years old gentleman, previously healthy, presented to local ER with acute dyspnea and confusion. Blood work is abnormal, WBC at 150,000, and the peripheral blasts were at 70%, making the diagnosis of acute leukemia. Patient presented with TLS, increased in potassium, creatinine, and phosphorus, with a uric acid of 7.5 and LDH of 3,000. Chest X-ray show bilateral infiltrate, and CAT scan was negative for bleed. So a bone marrow biopsy showed an AML with monocytic differentiation and normal cytogenetics, and rapid AML mutation panel showed FLT3 and IDH2 mutations. So Best evidence comes from RATFI trial. This is a randomized phase 3 study, double-blinded, patient with the age of 18 to 60, newly diagnosed, FLT3 mutated, got randomized on induction to 7+3 plus minus midostaurin from day 8 to 21. Midostaurin was also added to the consolidation and the maintenance for a year. And as we can see on the curve on the right side, median overall survival improved from 25 months to close to 75 months when midostaurin was added. Again, remember, those patients underwent transplant, and that's why they have very long median overall survival. And on this little graph under the curves, we could see subgroup analysis, and we can see that patient with ITD or TKD both benefited from the therapy. This is mostly due to the midostaurin being a pan FLT3 inhibitor. When they looked at the disease status at the time of transplant, CR1 patients showed better benefit to midostaurin versus placebo, while patients with more advanced disease like CR2 plus or active disease, they had no advantage taking midostaurin over placebo. Another study was done with quizartinib, which is another FLT3 inhibitor, and showed similar type of improvement in median overall survival. So this could be an alternative based on availability of drug or based on the financial and the insurance coverage. So just to continue our case, Mr. RATFI attained a complete remission after induction, and while in consolidation had a relapse disease. Again, the rapid mutation, and I do the rapid mutation panel on each relapse, so sometimes you get to catch a mutation that emerge. So this patient did not have any new mutation, still having FLT3 and IDH2. So what is the recommendation for next? Admire trial is their most recent, actually the second to most. Gilteritinib is considered to be more potent FLT3 inhibitor. Excuse me. It was tested in phase 3 randomized study versus best available salvage therapy. So people got randomized to MEK, FLAG, IDA, and others per a predetermined choice that their doctor had to make. And as shown here, with a single agent oral medication, we show improvement in median overall survival of 5.6 when you get salvage therapy to 9.3 months with a single agent. Patient for sure were allowed to go to transplant if they went to remission. And this is similar molecular or genomic map showing that resistant cases in this study were mostly based on the RAS pathway mutation that we mentioned earlier.
2 minutes. 2 minutes.
Okay. So other medicines we have inatizinib, and I will go fast on this because I want to get to this medicine. I'm sorry for the too many slides. Revumenib is a small molecule inhibitor of menin KMT2 interaction and is being investigated in patients with relapse and refractory disease, both for KMT2A and NPM1. There is a promising phase 1 study that shows a good response rate, and based on that, this ongoing study that was presented last ASH called Augment, which led to have patients of the age of 30 days with relapse refractory to receive this drug with primary endpoint response rate. And as we can see from the recent data presented, a median follow-up of 6.1 months. Overall response rate was close to 65%, which is significant for those type of population where you didn't have an option before. But overall, you could look at those confidence intervals, and responses were observed across all major subgroup, regardless of the population. Older and younger kids, benefit the same from this drug. This is the median overall survival. Again, 8 months in a very sick population. This is just for future direction, and I'm going to close by this slide. As we see from this table, multiple studies are ongoing to try to incorporate all those new agents in the upfront line. Mostly either backbone of A7 or 7+3, adding all those targeted therapy, FLT3, MLL, NPM1, IDH, all those mutations. Other approaches that, for example, are being attempted, those patients can get a resistant overcoming drugs as like MCL1, CDK9, and PEM kinase, etc. And lastly, on the last novel targeted, now we have immunotherapy in AML, and those antibodies could be against, for example, CD47 with macrophage activation, CD123, CD117, which is a c-KIT a receptor, and CD17. So more data to come soon, hopefully. Thank you.